do it? Well, we should do it before it's too late. If you wait too long, then all of a sudden you're in the middle of it and people are being rushed to intensive care or taken by the paramedics to the hospital and ED or whatever. You need to try and do it when the time's right. So how did I get lumbered with 2 end-of-life talks this morning? Well, the time was right. One elderly lady who's got lumbar onset motor neuron disease and has got quite a long time to live because it's progressing very slowly, gave me the throwaway line this morning. I was driving over the Westgate Bridge with my daughter the other day, and I thought crawling over the edge and dropping into the water would be a good idea. So that was the opening. I could not let it pass. I asked her how she was feeling, determined that she wasn't depressed, it had just been a passing thought. But then we got into what was she thinking about, etc., etc. And she told me straight out, without too much difficulty, that she didn't want any attempts at cardiopulmonary resuscitation. She didn't want to go to intensive care. She didn't want to be ventilated. She didn't want to have a gastrostomy tube. Well, at the moment she doesn't. She might change her mind. So we were able to talk and discuss those things and write them down and have a think about it, and it'll be in the letter to the GP and so on and so on. It just came up then. That was the right time. But the right time may have to be engineered. And a nice study in the United States showed that the patients wanted to talk about this, but their doctors didn't. I don't know what it's like for Australian doctors. I don't know enough of them. But I do know some who don't want to talk about this, as well as some who do it very, very well. You'll tell me what it's like down under. And if you're going to do this before it's too late and when the time's right, then you'll have to brush up your communication skills. All right? You have to brush up your communication skills. Now, this has come out in a complete mess. So this is where I now spit on Microsoft and Bill Gates and all his works. Okay? Yes. This was put together on an Apple computer, and this sort of thing frequently happens when you convert to PowerPoint on a non-Apple computer. What can I do? What I put up here was a list of the progressive degenerative neurological diseases with the time course, so that you know how long you've got in which to make your plans. So it begins, and you can't see it, but it might when Victor prints off the handouts for you. The first one is Creutzfeldt-Jakob disease, and it says less than a year from diagnosis to death. And they're very demented. You have no time to talk about end-of-life plans with those people. You're lucky if you can recognize the disease and talk to their families about it. So that's the quickest one. Motor neuron disease is next, usually between 1 and 4 years, but there are some exceptions. And we have to remember that in motor neuron disease, cognitive impairment can occur and can make it more difficult. Next one on the list is progressive supranuclear palsy. You can't see it, but it's there. They have about, well, you'll have learned this morning, probably no better than me, but I've got in my head sort of 5 to 8 years survival time. The question, though, is how long is it before they become incompetent to talk to you about their end-of-life choices? Multisystem atrophy, maybe 6 to 8 years. Some of them develop cognitive impairment. How long is it until they become incompetent? So just because they might live for 8 years doesn't mean you don't have to do the talk before they get close to death in case they become incompetent. In patients with Alzheimer's, life expectancy is getting longer. It's getting up towards 12 years from diagnosis. When do they become incompetent? In Huntington's disease, about 6 to 9 years, typically for people to live from diagnosis, they definitely become incompetent to discuss these things. Myotonic dystrophy, much, much longer. Parkinson's disease, typically much longer in the younger age of onset, but maybe only the same life expectation in older onset patients as in MSA and PSP. Spinocerebellar ataxia as well, I've already hinted there, 30-year plus some of these conditions. And some of the muscular dystrophies are much longer. But boys with Duchenne dystrophy are now living into their 30s. and they need to have discussions about end-of-life care because they become ventilator dependent. Now, predicting time of death so you can help people with making these decisions and discussions. Well, we're not very good at it. The other thing about our patients, the ones with these progressive neurological diseases, is that they have what has been labeled an entry-re-entry pattern of decline. So people with cancer get sick, they get treatment, they improve, everything goes along very nicely for a good while usually, but then they can develop secondaries, complications, all the rest of it. And once they're on the path of decline, it goes very predictably. The palliative care doctors are very good at predicting time of death in people with cancers. They're not so good, and neither are we, at our patients, because they can get an inhalation pneumonia, which very quickly becomes a devastating illness, yet you can rescue them and get them back to almost where they were before, some of them. In others, you may rescue them and they come back to some dreadful level of functioning that they would never have wanted. So you need to have a plan about what to do about these sudden catastrophic declines with inhalation pneumonia or acute sepsis, bladder sepsis, renal sepsis, whatever it might be. And there are some ways of helping you to do that, which have been developed looking at milestones and red flags. In motor neuron disease, we think we can be pretty accurate by the age of onset, the pattern of the illness, and the respiratory function. But in other conditions, people have been working to develop other milestones. And I don't know whether David Williams said anything about this morning, but he's one of the et al. On this paper in brain. And he was also in the et al. On a similar paper about clinical outcomes and red flags for decline in Parkinson's disease. This was all produced at National Hospital Queen's Square in London over the last couple of years. So in people with PSP and MSA, once they start having frequent falls, it's getting close. Severe cognitive disability means it's coming towards the end. When their speech becomes completely unintelligible, few patients who got to that stage lived more than another 6 months. Severe swallowing difficulties, similarly, as you would expect. When the patients had to take to a wheelchair, that was a pointer that they were now on the downward slope. When they had to use a catheter, when they had to go into residential care, these were pointers to help you. So once those sorts of things start to happen, you need to make sure you've got your end-of-life plans tidied up. And the time from diagnosis to the first milestone, well, PSP patients got there before the MSA patients who got there before the Parkinson's disease patients. And the shorter the time from diagnosis to the first milestone, the worse the outlook, the shorter the illness was going to be. The older the age at onset, the faster the disease went downhill. Now, David may have said all these things this morning, I'm not sure. I was doing my end-of-life care duty. And of course, patients who have other illnesses, older patients have comorbidity. It's a feature of illness and old age that you have more than one illness at a time. So they may have some heart disease, they may have had a stroke. Having these other conditions doesn't prevent you from getting those things. Now, how are we going to do it? Well, I know I'm talking to an audience mostly of therapists, so I apologize for putting sensitively at the top of the page. This is for the doctors. But maybe you need a little reminder about being sensitive as well. You need to do it at their speed. You need to ask and find out what they know. And you need to ask and find out what they want to know. And then you need to feed it to them bit by bit, depending on what they know and what they want to know. And most patients will tell you if you pay attention and listen. And remember, with our patients with PSP, you have to pay attention and be patient while you're listening, if you want to emphasize that. One way of getting into the conversation, if you think it's proving difficult or they're not taking you up on it, that I typically use anyway, is to say to them, there are some things which I really need to talk to you about. Have you made a will?